Hello everyone, welcome to this second event of a series of webinars on vasculitis. This is the Vasculitis Awareness Month. We have a series of webinar co-shared between ERN-RITA and EUVAS. You're very welcome to subscribe to the following ones. There will be a webinar on vasculitis every Tuesday during the month of May. And today it is my pleasure to hand it over to Gunnar Tomasson, who will chair this webinar on the recommendations for the treatment of ANCA Associated Vasculitis. Thank you everyone for being here.
Good morning or good afternoon and welcome to this webinar. Today's topics is the 2022 update of the EULAR recommendations for management of ANCA Associated Vasculitis, which was recently published. And we have two esteemed speakers, Alvise Terti from University of Trento in Italy and Benjamin Terrier, who are from Cousin Hospital in Paris, and they will cover this topic together. Alvise will start off with the structure of the recommendation, overarching principles and induction regimens. And then Benjamin will take over and discuss Avacopan, maintenance regimens and duration and treatment of infections or prophylaxis of infections. So you're welcome to write down your questions, which then will be addressed hopefully at the end of this session after both speakers have given their talks. So I don't think we have to wait any longer, and I will give the microphone to Alvise Terti.
Can you see my slide?
Yes.
Thank you. So thank you so much for the invitation. I'd like to start by thanking the scientific committee for this kind of invitation, and I'm really happy to be here. So today we'll talk about a EULAR recommendation. This is the outline. I just wanted to briefly mention that we will focus on the treatment of GPA and MPA. We are not gonna touch on the EGPA management since this has already been touched in a previous RITA Tuesday lunch. And as you know, ANCA Associated Vasculitis is a rare systemic autoimmune group of a heterogeneous condition which encompasses granulomatosis with polyangiitis, from now on GPA, microscopic polyangiitis, from now on MPA, and eosinophilic granulomatosis with polyangiitis, as mentioned before. These diseases are accumulated by the fact that they all have a small size blood vessel inflammation, but granulomatosis with polyangiitis is characterized also by the necrotizing granulomatous inflammation, whereas microscopic polyangiitis lacks of this inflammation. And as you know, these diseases are grouped by GPA and MPA, have an overlapping spectrum of disease manifestation, but there are anyway some differences, and specifically with granulomatosis with polyangiitis, with a predilection for the upper and lower respiratory tract, sinusitis, lung nodules, lung infiltrate, and so on. Whereas microscopic polyangiitis usually have more frequent and more severe kidney involvement. And as mentioned, there is a huge overlap in between the manifestation that you can see here on this slide. Today, we are going to talk about the EULAR recommendation, and all the persons here was part of this recommendation. Sarah Monti, Gunnar, Tomasson, and Professor Benjamin Terrier and me contributed to this recommendation panel. And as you can see, maybe by coincidence, but during the task force meeting, Professor Benjamin Terrier and me were sitting together, closer. As you can see, this is all the panelists that participated. The task force consisted of more than 20 clinical experts, mostly rheumatologists, but also internists, nephrologists from 15 European countries and USA, 2 methodologists, one convener and a co-convener, 2 fellows, and 2 patient representatives, and 1 health professional. From a methodological standpoint, we did a Delphi survey among the task force and identified 14 key research questions on the management of AV that was translated into PICO questions, and systemic literature review has been done on the main scientific medical databases. Then, during the face-to-face meeting, the results of the systematic literature review finding have been presented. The recommendation, the preliminary recommendation, have been discussed and voted, and afterwards, the level of agreement was anonymously given by email. This led to the production of 4 overarching principles and 17 recommendations that cover the diagnosis and the histology of the disease, the basics on the management and the therapy, including also the remission maintenance and the induction of remission, and then also the prophylaxis of the complication and the follow-up. As mentioned, there were 4 overarching principles. These are consensus-based, which means that these are not the results from the systematic literature review. These are considered to be fundamental for the management of the disease, as compared to the previous panel of 2016 of recommendation. These were actually specific statements with low quality evidence, and therefore it has been decided to move these 4 statements as overarching principles. And as you can see, this change the basics of the management of the patients. The first 2 overarching principles highlight the importance of the decision making with the patients, and that the patient need to have a clear explanation of the nature of the disease, of the treatment options, of the side effects, and of the prognosis. These will surely increase the adherence of the patient to the treatment. And therefore it's important, it's deemed to be important to do that. Then the overarching principle C highlights the importance of the patients to be periodically screened for treatment-related side effects and the comorbidities. One example could be for the patient treated with cyclophosphamide, the importance to do a periodical urine analysis to search for hematuria in order to screen for bladder cancer. And other examples could be check for the cardiovascular risk and comorbidities and so on. And then the last one highlights the importance of the multidisciplinary approach and the multidisciplinary management, especially for those patients with organ and life-threatening disease, which means the more severe forms of the disease. Recommendation number 1 and 2 cover diagnostics. Specifically, number 1, it's about biopsy. We recommend biopsy to assist establishing a new diagnosis and further evaluation. This was already present in the 2016 panel of recommendation. This is important. The biopsy is important not only for diagnosis, but also to distinguish active disease from damage and disease specifically, and this is particularly important for renal disease, for renal biopsy, for which several score to check for chronicity exist, like the burden classification or the Mayo Clinic one. And it's important anyway to mention that initiation of treatment should not be delayed while awaiting for the histological information. And there are just a few cases in which biopsy could not be suggested, such as in those cases in which there are unjustified risks, as for instance, the patient in anticoagulation therapy, or for those patients in which it's already known that there is a low diagnostic yield of the biopsy. A classical example is the lung biopsy, the transbronchial lung biopsy, in which the diagnostic yield is up to 12% of the patients, and therefore if there are lesions that could not be clearly attributed to AAV, an open biopsy should be taken into consideration. Recommendation number 2 is about the ANCA testing. ANCA test is important to support the diagnosis, and it needs to be done with antigen-specific assay as a primary method. This is actually stated also in a 2017 International Consensus Statement, which contains detailed information. I just want to highlight that the diagnosis should not be made on ANCA testing alone, of course, because it could be positive also in other inflammatory diseases, infections, or could be drug-induced. And anyway, the fact that ANCA serology is not relevant only for diagnosis itself, but it's also important for the subclassification of AAV, since it has been shown that the ANCA classification could integrate the clinical classification, carrying important information in terms of prognosis, outcomes, and therapeutic response. Recommendation for induction of treatment is divided based on the severity of the disease. For patients with GPA and MPA with organ or life-threatening disease, it's recommended the treatment with a combination of glucocorticoids and either rituximab or cyclophosphamide, whereas rituximab is preferred in relapsing disease. This recommendation derived from 2 high-quality randomized control trial, RAVE and rituximab, showing that rituximab is not inferior to cyclophosphamide. The trial used a specific scheme that imply 375 milligrams per square meter every week for 4 consecutive weeks for induction of remission, but it has been shown to be non-inferior and as effective as the rheumatoid arthritis scheme, which is 2 infusions of 1 gram 15 days apart. Then the novelty of the recommendation is that in the RAVE trial, it has been shown that rituximab is, as you can see here on the slide, is more effective in relapsing disease as compared to patients with newly diagnosed disease, which means that testing the rituximab for the induction of remission is more effective in relapsing patient. Here in the slide, relapsing patient is called severe flare patient, because as you know, RAVE patient in the RAVE trial, patient with both newly diagnosed and relapsing disease were enrolled. So not only the rituximab trial showed the superiority of rituximab for relapsing disease, but more recently the RITA trial, which is a single-arm trial, showed that relapsing GPA and MPA patient could be safely induced with rituximab that could reach in up to 90% of patient remission in the first 4 months of therapy. And this is the ground on which the recommendation advise the use of rituximab, the preference of rituximab in relapsing disease. And then there are also other reasons linked to the safety. The fact that, of course, infertility and bladder cancer, bone marrow failure, myelodysplastic syndrome is associated with the long-term use of cyclophosphamide. So rituximab may be preferential in all these situations. For the non-organ and non-life-threatening GPA or MPA, the level of the treatment suggested is the combination of glucocorticoids with rituximab, While as a first-line therapy, while methotrexate and mycophenolate mofetil can be considered as alternatives of rituximab, this is in contrast to the previous set of EULAR guidelines of 2016. In this case, rituximab have been considered as the first line, in part because RAVE and other trials that test rituximab in AAV included also non-organ and non-life-threatening patients to be tested, showing that it is effective also in this subset of patients. And again, more recently, RITA trial showed that in 66 out of the 69 patients with non-life, non-organ threatening disease, reached remission with just rituximab. NORAM and MySeq are the trial that I won't show here for brevity that show that methotrexate and mycophenolate mofetil could be used for induction of remission and are not inferior as compared to cyclophosphamide for induction of remission, but in both the trial during the follow-up the rate of relapse is higher, and anyway the doses of glucocorticoid used for induction is significantly higher as compared to those currently recommended. So in practice, guidelines suggest to use rituximab as a preferential therapeutic agent, also in non-organ and non-life-threatening disorder, while keeping mycophenolate mofetil and methotrexate in case of intolerance or contraindication to rituximab. Then there is the novelty of this panel is the use of glucocorticoid. Glucocorticoid reduced dose, a reduced scheme as tested in the PEXIVAS trial, show that it could be as effective as the standard scheme, and in the meanwhile it could reduce the severe infection during the first year of approximately 7 to 8%. So in other words, as you can see here reported, the reduced dose proposed by PEXIVAS here in the table is able to reduce significantly the cumulative dose of glucocorticoids in the first 6 months of approximately 60%. Of approximately, 40%. And as you can see here in the image on the right part of the slide, there is a clear reduction as shown for every body weight category by the continuous line, which represents the reduced dose, as compared to the dotted line that represents the standard dose. PEXIVAS scheme is not advised only by the EULAR 2022 guidelines, but it's also recommended by the other guidelines like ACR 2021 and KDIGO guidelines 2021. But it's worth it to mention that it's not the only scheme that aim to use less glucocorticoid for induction of remission. Also, the control arm of the Advocate trial used less glucocorticoid as compared to the previous trial, and specifically the LOVAS trial, which is conducted on less severe patients as compared to the PEXIVAS one, is also a positive trial that showed that less glucocorticoid could be used for induction of remission. Then the plasma exchange may be considered as part of adjunctive therapy to induce as an add-on therapy to induce remission in GPA or MPA in selected cases when creatinine is higher than 300 micromoles per liter due to active glomerulonephritis, whereas alveolar hemorrhage in GPA and MPA, in alveolar hemorrhage of GPA and MPA is not recommended. This is, as you know, in 2020, the PEXIVAS trial was published. This it didn't show that the use of PLEX as in routine practice, in addition to the standard of care, adds something in terms of the composite outcome that include death for any cause and end-stage renal disease. And as you can see from the image, 28.4% in the plasma exchange group and 31% in the control group reached the primary outcome. So this means that, according to this trial, the addition of PLEX did not improve the primary endpoint of this trial. But recently, meta-analysis pulling together 9 randomized controlled trials with approximately 1,000 patients, all of them testing the role of PLEX, show that there could be a benefit in end-stage renal disease at 12 months when adding on the PLEX to the standard of care. Which means that the patients were stratified by the baseline creatinine to stratified by renal involvement severity, and the patients that have a higher creatinine benefit the most from the use of PLEX, and specifically the number needed to treat of patients with a creatinine higher than 300 micromoles per liter was 21.7, which means that 21.7 patients need to be treated to avoid one end-stage renal disease, whereas for those patients with a higher creatinine, more than 500 micromoles per liter, 6.25 patients needs to be treated to avoid an end-stage renal disease. This is linked anyway with an increased infection rate, which is higher for those patients that have high creatinine, with a number needed to harm, which is 11.6 for those patients with more than 300 micromoles per liter of creatinine, which means that 11.6 patients needs to be treated to get a serious infection within the first 12 months, whereas 7.24 patients needs to be treated to have severe infections within the first 12 months. So in conclusion, the guideline says that PLEX have to be considered in selected cases with GPA-MPA with serum creatinine higher than 300 micromoles per liter. Finally, the last recommendation that I present here is that refractory disease. Refractory disease is quite a rarity, and it needs to be considered when the patient does not respond in the first weeks of therapy. There is not improvement. The first thing to do is reassess the disease and comorbidities to make sure that it's really a refractory disease and is not damage or comorbidities. If the disease is really refractory, then there are several approaches, but it's worth it to mention that there are not high-level quality study specifically focusing on refractory diseases. So the treatment is mainly non-evidence-based, and it goes from increasing the glucocorticoid dose, particularly only if minor symptoms persist, switching from cyclophosphamide to rituximab or from rituximab to cyclophosphamide, or the combination of rituximab and cyclophosphamide, particularly in those cases with organ and life-threatening disease, or finally, adding intravenous immunoglobulins, particularly in those cases in which there are an increased risk of infections. Of course, there are also new off-label treatments, but usually this kind of decisions are made in conjunction with the referral center dealing with these diseases. So to conclude this first part of the recommendation, I spoke of the importance of biopsy and ANCA testing to assist the diagnosis. I show that cyclophosphamide is as effective as rituximab in induction of remission, and that the rituximab should be preferred for induction in relapsing patients. Then that reduced glucocorticoid regimens is equally effective and less toxic than standard glucocorticoid therapy, and then that PLEX should be considered in those patients with rapidly progressive glomerulonephritis with a creatinine higher than 300, while in alveolar hemorrhage, there's no evidence to suggest the use in isolated alveolar hemorrhage of PLEX in addition to the standard of care. Thank you very much for your attention.
Thank you so much, Alvise, for a very nice talk. And now I'll hand it over to Benjamin Terrier for the second part of this webinar. And I remind you to that it's possible to write your questions in the chat box.
Thank you very much, and thank you, Alvise, for the first part and the nice picture when we were having lunch during this recommendation. So I will discuss the next recommendation that were presented by the group. I have few disclosures, but some of them are mainly related to the eGPA management, but also regarding Avacopan. So Alvise showed you that one of the major improvements of the last recommendation were related to reducing the cumulative dose of glucocorticoids, and especially with the Pexivas regimen that demonstrated non-inferiority but a decrease regarding the side effects. In this approach to try to reduce the cumulative dose of glucocorticoids, you probably know that there is a new player in the game, which was approved by the FDA, the EMEA, which is the C5a receptor 1 antagonist Avacopan. And so in this objective to reduce the cumulative dose of glucocorticoids, the use of new therapeutic agents that may reduce the exposure to glucocorticoids is also an option. And Avacopan is really the new treatment that appears for the management of ANCA Associated Vasculitis. So the study, which is the Advocate trial that was published in 2021 in the New England Journal of Medicine, evaluated the Avacopan use in combination at the very beginning with glucocorticoids to what we could consider to be a conventional glucocorticoid regimen. As you can see on this figure, in red, you have the dose of glucocorticoids that was used in the Avacopan group. So as you can see, it was mainly during the beginning. And in light gray, you have the dose of prednisone, which was used in the control group. So first, there was a significant decrease in the glucocorticoid exposure between the two arms, what was, of course, the objective of this trial. And if we analyze the results of the Avacopan study, you can see that there was a non-inferiority in the rate of remission at week 26. Avacopan or prednisone were used in combination with cyclophosphamide or rituximab. So the rate of remission was similar between the two groups at week 26. So there was a non-inferiority that was achieved, but at 52 weeks, there was a superiority of in the Avacopan group regarding comparison with the prednisone group, but the dose of prednisone in the prednisone group was discontinued at week 20. So following these results of the Advocate study, there was a recommendation that was made for Avacopan, which was the first time in the EULAR recommendation. That was the following recommendation, that Avacopan in combination with rituximab or cyclophosphamide may be considered for the induction of remission in GPA or NPA. It was not yet evaluated in eGPA, for instance, and it should be considered as part of a strategy to substantially reduce the exposure to glucocorticoids. So the statement from the EULAR was mainly to reduce the exposure to glucocorticoids, even if we could discuss in the future some other positioning of the drug in the management of GPA and NPA. The next recommendation were mainly related to the maintenance of remission, because if we analyze some large studies that were published during the last decades, the CICASAREM study, the VEGAN study, the REF study, you can see that relapses after the achievement of remission is a major issue. And it's probably in 2024 more complicated to maintain the remission than to induce the remission in ANCA-associated vasculitis. And one very important aspect is that in daily practice, we know now from different studies that the presence of PR3 ANCA is highly associated with an increased risk of relapse, much more than in patients with MPO ANCA. So some of the recommendations from the EULAR really focused on the maintenance therapy. And the first statement was that for maintenance of remission, after the induction of remission, as Alvise explained to you, we recommend treatment with rituximab. And there is so far no discussion in terms of evidence-based data that rituximab is the most effective strategy to maintain remission. But because there is some countries for which rituximab may be more challenging to use, or in patients for which, for instance, there is some anaphylaxis to rituximab, azathioprine or methotrexate are still considered as alternative to rituximab. So just to remind you that this recommendation is mainly based on the results of the Remission study that was published in the New England Journal of Medicine in 2014, and which compared azathioprine and rituximab to maintain remission. And as you can see, there was a 5-fold decrease of the risk of relapse with rituximab in comparison with azathioprine. So the next question that was addressed by the recommendation was how use the rituximab, how long use the rituximab as a maintenance regimen. And so the data we have are not so many. There was recently the pooling analysis of the data from Remission 1, Remission 2, Remission 3, which compared, in fact, a fixed dose of rituximab every 6 months to an individually tailored approach based on the CD19 or the ANCA positivity, and also regarding the duration of the rituximab, so 24 months in comparison with 48 months. What this data showed, and it was published very recently, is that in fact the tailored regimen based on CD19 or ANCA titers should be probably not considered anymore, because it is associated with an increased risk of relapse in comparison with the systematic infusion of rituximab every 6 months. The other discussion was about the duration of the rituximab. This pooled analysis from the Remission trials evaluated a duration that was for 18 months in comparison with a duration of 36 months. And in fact, the extension of the rituximab for a longer time was not so obvious in terms of decreased risk of relapse, and especially since the COVID-19 pandemic, which questioned about the balance between the benefit and the risk. And more recently, the RITA study, which was what Alvise started to show you, so it was mainly dedicated to patients that received only rituximab as an induction regimen. It was only patients that were relapsing patients. And so Alvise showed you the rate of remission after induction regimen, but this study was mainly evaluated to assess the efficacy to maintain the remission in this specific population of relapsing patients receiving rituximab as induction therapy, and with the comparison of rituximab and azathioprine. And the difference with the Remission study was what the dose of rituximab was not 500 milligrams every 6 months, but 1 gram every 4 months. And as you can see, there was a superiority of rituximab in comparison with azathioprine, but even if it was not a head-to-head study with the Remission and the RITA regimen, the benefit to use more intense maintenance regimen does not appear obvious in comparison with the dose. But because the dose was not directly compared, the recommendation from the EULAR regarding the duration of the maintenance tried to be quite inclusive in terms of all the data that were available. And so that's why it was recommended that the maintenance regimen should be continued for 24 to 48 months following the induction of remission in new onset disease, and in patients with relapsing disease or with an increased risk of relapse, some longer duration of treatment should be considered. But no clear recommendation can be made because it's mainly based on a balance between the benefit and the risk, so an individual evaluation. And for instance, the CADIGO recommendation, which are the recommendation from the nephrologist, for instance, proposed some list of factors that increase the risk of relapse and that can help practitioner to decide in which situation using longer treatment. And as you can see, in terms of baseline factors, the fact to be peer 3 ANCA positive patients or to have a GPA, also the patient with a relapsing disease or the patient who are still with positive ANCA at the end of the induction regimen were some of the factors that was potentially interesting to evaluate the risk of relapse. But we are still lacking so far maybe some tools that will help the physician to individually assess the balance between the benefit and the risk for longer treatments. Since we are using some quite effective regimen, but for a long time, that we know that are associated with B-cell depletion, the question of the prevention of infection is a major issue. Alvise showed you that one of the major results of the PEXIVA study and using lower dose of glucocorticoids was especially because it was associated with a less important risk of severe infection. So the EULAR recommendations evaluated and proposed, some statement to try to decrease the risk of infection or to better identify the patients at higher risk of infection. And what is clear in the recommendation is that the measurement of serum immunoglobulin concentration prior each course of rituximab is recommended to detect secondary immunodeficiency and especially related to the decrease of IgG or IgM. The other aspect is regarding now the antibioprophylaxis, and there is also a recommendation in patients treated with rituximab or cyclophosphamide and or high dose of glucocorticoids, and it's now clearly recommended to use the combination of trimethoprim and sulfamethoxazone or the cotrimoxazole as a prophylaxis for both pneumocystis jirovecii pneumonia, so pneumocystosis, but also severe infections. And the second part of the response regarding the other severe infection has now some really high evidence data, and especially if you consider a study from the group of Cambridge published more than 6 years ago, which evaluated in patients receiving rituximab as induction then maintenance. They evaluated the risk of severe infection, and they demonstrated that the prophylactic use of trimethoprim and sulfamethoxazole was also associated with a decrease in the frequency of severe infection. And also, as an ancillary study from the REV trial that evaluated rituximab in comparison with cyclophosphamide to induce remission, the use of trimethoprim and sulfamethoxazole was also associated with a lower risk of severe infections, mainly bronchopulmonary infection, and it was true as well in patients receiving rituximab as induction or patients receiving cyclophosphamide and azathioprine as induction regimen. So that's why the use of this strategy is beneficial for the patient as a prophylaxis of pneumocystosis, but also of severe infection. So to conclude with the additional recommendations following what Alvise told you, clearly Avacopan is a new player in the game and should be considered for the induction of remission in combination with cyclophosphamide or rituximab to substantially reduce the exposure to glucocorticoids. And it's what was chosen by the EULAR for this recommendation, that the duration of remission of GPA and MPA using rituximab should be used for 24 to 48 months. And after some longer duration should be assessed in an individually based approach. It is also recommended to monitor the risk of immunoglobulin deficiency related to the use of rituximab with the measurement of immunoglobulins, and also the recommendation to use trimethoprim and sulfamethoxazole, not only as a prophylaxis against pneumocystosis, but also of other infection. And once again, I show you the pictures, the picture of the EULAR recommendation that were hosted in close to Stuttgart by Bernard Helmich, and I will be very happy with Alvise to discuss about your potential question.
Thank you very much for these nice and clear presentations. We have a few questions. The first one is on the combined use of rituximab and plasmid chains. It's a question from Grace, and who said that was a question about the order to give these treatments, worrying about that rituximab might be washed out during the plaques. Would you start plaques first and then give rituximab right after, or even wait for a longer period of time, or would you start rituximab and also plaques simultaneously? Or perhaps you don't use plaques mass change that much. I don't know.
I don't know if we have different opinion or response. So I like to also to hear from Benjamin. Obviously, in our hospital, in our institution, the one that do the plaques is the nephrologist. So we usually decide together when to do that and the timing. Of course, the risk might be that rituximab might be washed away. So the nephrologist that I work with tend to use the 375 scheme instead of the 1 grams. So in order to kind of maximize the dose of rituximab, considering the plaques sessions, but I think it's something linked to the expertise and not really evidence-based. Actually, there are 5 to 7 plaque sessions, so obviously sooner or later you will wash away something. I don't know, Benjamin, what's your approach? So you have to take into account that, I guess.
No, I agree with you. First, that's true that when we consider plaques, it's mainly in very severe patients, and that's true that cyclophosphamide is probably more frequently considered in these patients than rituximab. But rituximab, there is many data suggesting that it could be an interesting strategy even in severe patients. Exactly like Alvise said, we preferentially use the 4 infusion regimen rather than the 1 gram 2 weeks apart, to be able to be sure that we infuse maybe more frequently the drugs, and all the time we do the infusion of rituximab just after the plaques, because there is plaques every 2 days if we consider that, and we consider that doing the rituximab just after the PLEX will allow for 2 days the drug to be active. But as Alvise told you, we also more frequently use the 375 milligrams per meter square every week rather than 1 gram to support.
And that's an active field of research. I would add this one in severe renal disease, if rituximab could suffice or cyclophosphamide could, it's to be preferred. Actually, the KDIGO guidelines says that with level of creatinine more than 4, cyclophosphamide could be preferred. And it's actually not so evidence-based as compared to the level of evidence that we have with rituximab, but it's true that in real life, this is something that most of the center take into account. Actually, there are not a lot of RAID studies have been conducted in non-severe patients, whereas rituximab studies have been conducted in severe renal patients, but use cyclophosphamide plus rituximab and not only rituximab. So this is a gap in the literature for us. So it's not super clear right now. It's not super evidence-based what is the best treatment to do. Benjamin, I don't know if you would like to add something or...
No, I totally agree with you. There is this regimen that combine both drugs, and it's especially in France probably underused in comparison with what we could do. You know, when we look at the data that are presented, for instance, at the American College of Rheumatology or the EULAR, that the nephrology world more frequently use this combination therapy. And it's something that in rheumatology or internal medicine, we probably do not use enough because we have also less severe patients. But I totally agree with you.
Thank you so much. I have a question about the recommendation that rituximab should be preferred over cyclophosphamide for induction. And this is, you mentioned the RAVE results. What about the situation when rituximab was originally given for induction and maybe even in lower doses for remission maintenance? Should patient relapse then? Is rituximab still the favored agent?
Do you want to go first, Benjamin? Since it's...
No, I'm not sure that I have understood everything, so that's why I will complete my understanding with you. So you can go.
So the question was how long to go on with the 500 milligrams for maintenance as compared to other approaches, right?
No. Why is you say that rituximab is preferred over cyclophosphamide, or the recommendations say that the rituximab is preferred over cyclophosphamide for remission induction among those with relapsing disease? But is that also the case when the original disease activity was treated with rituximab, even for both for induction and even for maintenance? Should you then also reinduce with rituximab in that scenario?
So this is, as mentioned, this was due to the fact that evidence, because obviously, spoiler alert, recommendation is based on studies, and high quality study obviously have a higher weight for the recommendation. So that's why this is actually the conclusion of the recommendation for induction of remission of relapsing disease, show that in relapsing cases it should be preferred. In patients that are induced with rituximab and then that have actually relapsing disease, my approach is actually to use rituximab again to do the reinduction. Of course, as this is kind of linked with what Benjamin was saying before, there are risk profiles which is based on clinical diagnosis, having already had a relapse and having a PI3 positivity for ANCA, there are three non-independent risk factors for having a relapsing disease. This is actually the subset of patient that it's treated and retreated with rituximab in order to, because it's actually the one in which this patient seems to respond better. The point is, relapsing disease will relapse, tends to relapse a lot of times. So rituximab is apparently the best drug that we could have at the moment, clearly available. And that's why it's usually preferred for this kind of for relapsing disease. So that's also reflect my approach, actually.
Thank you.
Yeah, I totally agree that since with rituximab, we don't have the same issue that we had before with cyclophosphamide regarding the cumulative dose. I would say that we are less frightened about the fact to reuse rituximab. And also what appears to be quite clear with rituximab is that if it was effective initially, it will remain effective for further relapses. And so that's why whatever the initial induction regimen that was done, we will use rituximab, because if it was cyclophosphamide before, we will decrease by using rituximab, and we have the data from the REF study. And if it was a relapse after rituximab, because, for instance, the treatment was discontinued for a long time, it was effective initially, and so we have data suggesting that it will be effective again. So I think, we will use it again.
Thank you. And there is some interest in the audience for the regarding the measurement of serum immunoglobulins. The recommendations state that they should be measured prior to each course of rituximab. But what then? How should the findings be interpreted? Should some mild spurs of immunoglobulins always lead to something, some changes in management when there are not much infections apparent?
I think there is something which also depends of where you are in the world, because, for instance, the indication and the requirement to consider the use of intravenous immunoglobulins as prophylaxis really depends and is different according to countries, because the cost is not always the same. And clearly, what is it important to measure the immunoglobulins? That if we look at in France, for instance, to consider the use of immunoglobulins in patients with secondary immunodeficiency, like those induced with rituximab, you have to have a serum IgG levels lower than 4 grams per liter, and you have to be refractory to antibiotic prophylaxis using cotrimoxazole or amoxicillin. So it is important to get the value and the measurement, because it will be included in your decision. But that's not because you have, for instance, 5 grams per liter of immunoglobulins that you will do in our practice all the time immunoglobulins. So you have to consider first the value, and also, do you have some infection or not? Because it's not always the case. And sometimes you have patients with a higher measurement that experience some infection, and especially when there is some structural damage into the lungs, for instance. So I think it's important to get it, but not only because you will, in any case, consider the infusion of immunoglobulins.
Yeah, I completely agree with this. This is the same attitude that I have, with only one exception. If the immunoglobulin is really, really low, like at least less than 2.5 or 3, then I might consider to do like a short-term immunoglobulin anyway, even if the patient does not have infection, because if the immunoglobulin are very low, it might be that infection is not just about if, but it's about when infection is going to happen. But that's anyway something that could be discussed. Is not actually mandatory. It's just a personal approach.
And of course, as you mentioned, with the trimethylprim sulfamethoxazole, that should in generally be be given also, at least during the induction. Do you continue the prophylaxis beyond the induction phase? Do you also give it for patients receiving remission maintenance doses of rituximab?
In our experience, since we observed in the main recent studies that were mainly assessing the maintenance, 1 or 2% of patients with pneumocystosis, we continue the trimethoprim sulfamethoxazole also during the maintenance phase. Usually, even if it's out of evidence-based, we maintain the treatment until 6 months after the last rituximab infusion to be quite in line with the B-cell repopulation. I don't know what you do in Italy, Alvise, regarding duration.
The same. It's about 3 months after cyclophosphamide and 6 months after rituximab. Also because actually there is also a reduction not only of PJP but also generally of infection. So it's protective and it's an attitude that we have to.
Well, thank you very much. I think the time is up. It's 1 o'clock in Central Europe, and I thank the speakers, especially for their great talks, and the organizers for hosting this event. And I will conclude the webinar. Thank you.
Thank you very much.
Thank you. Bye.
Bye.